Good afternoon. Thank you to KSOS for the opportunity. A slice before the darkness fell. This is the case of a 51-year-old diabetic patient who presented with redness for the past 1 month, which was treated as conjunctivitis, and he had intermittent double vision for 1 month. So he had no history of trauma, thyroid abnormalities, and his Hirschberg's reflex was central, but on cover test he was ortho in the primary, though he had esotropia in the left gaze, suggestive of a left lateral rectus paresis. The right eye was normal. Left eye had a mild axial proptosis, but when you look at the vessels, it is like a corkscrew-shaped vessels, and the fundus evaluation showed a hyperemic disc. So suspecting carotid-cavernous fistula, send the investigation MRI and MRV, which showed a prominent left superior ophthalmic vein. So I want to confirm that, did a digital subtraction angiography, which showed a partially thrombosed esophy. The green circle, you can see the fistula, and the blue arrow is the drainage into the left petrosal sinus. So this is a Barrow's type B indirect CCF between the meningeal branches of right ICA and left cavernous sinus. So he was advised endovascular embolization, but he declined the treatment and he was prophylactically put on anti-glaucoma medications. But after 2 months, what happens? He suddenly comes up with proptosis, severe redness and pain. On examination, vision dropped to 6/60. There was chemosis, thickened and keratinized conjunctiva, frozen eye with absolute no movements. And cornea was covered with 360-degree conjunctiva. He had a grade 1 RAPD. And fundus showed a hyperemic disc suggestive of an impending compartment syndrome. Neuroradiology department, they did a Doppler which showed a non-visualization of superior ophthalmic vein. That means there is a complete thrombosis of this shunting SOV. Now what to do? There was no reflux between the carotid and the cavernous sinus, so there is no point in doing endovascular procedure. So he was started on anticoagulation with a subcutaneous heparin to prevent the progression into the cavernous sinus, to prevent the thrombosis and central retinal vein occlusion. So he was referred to me for salvaging the eye. So at this point, I have to save the eye and also the vision. I did a lateral canthotomy with a cantholysis with a temporary tarsography. So post-operative, after 1 week, proptosis reduced, chemosis also reduced, EOM started regaining. This is the picture after 1 month. His vision regained 6/9, clear cornea and almost full EOM. So we know the types of fistula are direct and indirect. And here, though spontaneous closure of direct fistula is uncommon, 20 to 60% of indirect fistula closes spontaneously. In this case, sudden complete thrombosis of SOV has resulted in sudden worsening of proptosis with chemosis suggestive of an impending compartment syndrome. So in order to reduce the intraorbital pressure and to save patient's vision, lateral canthotomy and cantholysis was performed. So the timely intervention of these 4 procedures, lateral cantholysis, tarsography, anticoagulation, hit the heparin, along with the anti-glaucoma medication, saved the patient's eye and vision. Thank you. This presentation got 2nd prize in the Indian Neuro-Ophthalmology Conference in the year 2025. Thank you.